Good afternoon, everybody. My name is Rodrigo Alcantara. I'm a huge fan of the contrast mammography, and I had the opportunity to be one of the first to try the novel technique of CSM-guided biopsy, and would like to share with you our experience. Here are some of my disclosures, and this is the hospital where I work, Hospital del Mar, in beautiful and sunny Barcelona. We work in a multidisciplinary breast unit composed by various specialists. In the breast imaging section, there are 4 dedicated breast radiologists and also 6 full-time radiographers. We are not a very big hospital. In 2019, we performed around 500 contrast-enhanced mammographies. We use CSM mainly for symptomatic patients and also as a problem-solving tool. As you can see, since 2019, our number of MRI-guided biopsy has been decreasing, while contrast biopsy have increased. At that time, 11 cases. Right now, March 2021, we have performed around 40 cases of CSM-guided biopsy. Until 2016, our first imaging technique was conventional mammography, before purchasing a digital breast tomo equipment. Although mammography has been shown to be very valuable in the early detection and diagnosis of breast cancer, it's widely recognized that it's not a perfect test. The sensitivities of the documented mammography examination varies between 60 and 89%, worsening performance with an increase in parenchymal density. The detection rate depends on the density of the breast. The masking effect increases number of interval cancers, and breast density itself is an independent risk factor for breast cancer. The digital age in radiology has allowed the development of new approaches, such as the association of dual spectral mammography excision and administration of iodine-based contrast. The technique itself was approved in 2018, same year actually as the tomo. What exactly is the contrast mammo? Briefly speaking, it's based on the principle of tumoral neoangiogenesis and the use of 2 different photon spectra, specific filters, and dedicated software. What happens is that after the administration of iodinated contrast medium and by a subtraction algorithm, areas with neoangiogenesis are shown. This is the same principle as MRI. And ultimately, what we do is adding information, functional information, to a conventional morphological technique. Encouraging clinical trials have been published in the past 10 years on the usefulness of CSM. I will do not a very detailed review of the literature, just comment on some publications, such as that one of Dr. Joe Kelson, for example, who points out that in a diagnostic context, CSM has greater sensitivity than a normal mammal, even in women with dense breast, similar to MRI. In addition, other studies have shown that low-energy CSM images are non-inferior to FFDM. This allows a routine mammogram to be omitted in these patients. There is also a good agreement between the tumor size in CSM compared to MRI. The sample on the side, you can see that there's an excellent correlation of that infiltrating ductal carcinoma on CSM and with the MRI subtraction and the micro and ultrasound. Here again, sensitivity values around 100% and maximum specificity in the article published by Joe Kelson in 2013. With respect to the tumor size prediction, the contrast mammo practically wins, with the exception of an extensive multifocal cases. Some potential indications: suspected breast cancer in the clinical exploration is the standard of care in our institution, Hospital del Mar. We initially perform a CSM instead of a mammo for symptomatic patients over 40 years of age. Of course, it's also useful for MRI contraindications and allows us a quick tool to access post-surgical changes and rule out recurrence. As MRI, it can be easily used as a problem-solving tool for inconclusive findings in other imaging techniques due to its high sensitivity and negative predictive value. Whereas we can use it for staging of breast cancer, dense breast and intermediate risk, and last but not least, for the follow-up of response in patients with neoadjuvant chemotherapy. About our protocol, one change we made was to implement the CSM as the first imaging technique for symptomatic patients, replacing the standard mammo, as you can see in our department's pathway. The goal here is to perform all necessary biopsies in a single visit and to minimize additional procedures. The use of CSM makes the need for a second look ultrasound, inclusive after an MRI, much less likely, and also sometimes it is not even necessary to perform this MRI. So how do we do that? We use, of course, an IV administration of iodinated contrast media with an automatic injector. At 2 minutes, we start with a normal 4-view mammogram with simultaneous low and high energy acquisitions. Remember that the high energy is used to produce the final recombined or subtracted image. Therefore, the result will be 8 images. We usually start with a symptomatic MLO and an additional late LM view. It's done in the case of any suspicious enhancement. The entire excisions take about 7 minutes. Let's review some cases of my department in the last years. Examples of lesions with no enhancement at CSM. On the left, a symptomatic palpable breast lump and an hamartoma with no enhancement in the upper outer quadrant of the right breast. On the right, we can see 2 different lesions without enhancing, a circumscribed oval mass, which was a stable fibroadenoma, and 2 round masses in the upper quadrants with negative enhancement that is a classical sign of simple cyst. Findings that did not enhance and had no clinical or imaging suspicion criteria were considered benign and scheduled for appropriate follow-up. Possible false negative lesions to the technique are findings that may not be accurately included in the standards views due to their depth and external location, and some small clusters of calcifications due to the CIS low grade or atypical ductal hyperplasia. Some patients with history of lumpectomy that were referred to us with doubtful changes in the physical examination of the surgical scar. The center image is a biopsy D breast with heterogeneous calcifications. It was palpable, but there is no enhancement. The case on the right was a first examination at our center with no available prior exam. So I highlight here the presence of an ill-defined mass that shows negative enhancement and ended up being an oil cyst and fat necrosis, so no biopsy required. This case is a 33-year-old woman who came for a palpable mass of 3 months. For her age, we first did an ultrasound where we find it irregular, hypoechoic, shady, rather ugly mass. Considering that the degree of suspicion was high, we decided to complete with a CSM. In low energy, we can see it's likely that there's a mass with imprecise margins hiding in the superior of the right breast, but with no enhancement associated. Due to the clinical and ultrasound features, we decided to perform a biopsy, obtaining these very dense brownish samples that results in histopathology of extensive fibrosis. The patient was a diabetic type 1, and we did only follow-up after that. It's not exactly the same concept, but this article, this paper of 2018, show in the tracking of patients with intermediate risk and dense breast, where they also confirmed high sensitive values, detection rates of 13 compared to 3 of ultrasound, and attention, they do not refer clear benefits in adding ultrasound in case of a negative contrast enhanced mammo. Secondly, all the enhancing lesions, the non-enhancing lesions that were ultrasound biopsied in this paper were negative, which means they were all false positives. CSM studies are not yet considering the ICR virus. We use a mix of lexicon from the mammovirus and the MRI virus. So in this way, we can talk about mass, non-mass, focus, and let's go through some cases. This is two examples of benign enhancing findings. On the left, two oval circumscribed enhancing masses with mild enhancement, kind of oval and microlobulated ultrasound, and biopsy-proven fibroadenoma. In the periphery, a small foci of adenosis is observed. On the right, it's a marked enhancement in a 9 millimeters circumscribed dense mass at 3 o'clock. Biopsy demonstrated fibroadenomatoid changes and usual ductal hyperplasia. Microscopically, there is a predominantly chronic inflammatory infiltrate with reactive changes, which in general increase vascular permeability and favors this enhancement that we see. The next case is a 60-year-old male. Attention, this is a man with gynecomastia and a palpable lump. As you can see on the right above, a classic image of subareolar fibroglandular tissue with no enhancement associated. On the other hand, in the inner quadrants of the left breast, there is the oval-shaped and circumscribed sort of lobulated mass that did not enhance and was biopsied with a result of a cavernous hemangioma, a rare benign vascular tumor. Talking about malignant findings, this is a 50-year-old patient, first screening image, and we see that there's an extensive cluster of fine pleomorphic calcifications at 3 o'clock that show mild enhancement and recombined image that correlates very well with the enhancement at MRI, with the result of a ductal carcinoma in situ. And this is another very interesting case. It's a 49-year-old patient. It was a palpable lump in the left breast. CSMs shows a marked asymmetric no-mass enhancement of regional distribution affecting most of the upper outer quadrant of the left breast. The enhancement at CSM, it's very similar to the MRI, and histopathology results of extensive ductal carcinoma with microinvasive component, as you can see in this circle area. This is a case of interval cancer, 65-year-old women, recurrent participant of the breast cancer screening program. It had been invited for another routine biannual mammogram on March 2018. She was asymptomatic and neither the two readers found any suspected lesions, so patient was not recalled. The patient searched after 8 months for the gynecologist consultant due to a perception of skin retraction, as you can see here. So she was again referred to us. In this case, having a reported previous normal mammo, we decided to increase the sensitivity with the added value of the iodinated contrast. In CSM, we can see a multifocal invasive lobular carcinoma that fits well with the MRI. Another time, an interval cancer. There are also very difficult cases. Who knows how the CSM could have changed the initial approach. This is a 48-year-old woman with a history of left bifocal breast mass and mastectomy 8 months before. And lumpectomy. With the CSM, she was referred to us due to a palpable lump we did initially the ultrasound, where we saw this irregular mass that mistake to us for an hematoma or residual change. We decided to add CSM, and we can see that the CSM shows two poorly defined, slightly enhancing lesions located near to the surgical scar, and it was invasive triple negative carcinoma 18 months after surgery. There is 44-year-old male man referred to us for evaluation of progressive gynecomastia. On the left side, on the right side, as I showed you before, the gynecomastia should not enhance, and there is a normal one. But on the left side, there is this image of moderate amount of fibroglandular tissue, and here on the upper quadrants that shows a marked enhancement. There are some microcalcifications, some calcifications as well. And on ultrasound, there is an heterogeneous area with shed wall and ductal occupation. The biopsy result was of several foci of ductal carcinoma in situ of low intermediate nuclear grade with comedonecrosis. No invasive component was found, and the size of the neoplasm is approximately 55 millimeters. Let's go to another CSM case. 61 years old women with a palpable lump in the right breast in low energy. You can see an irregular mass here in the lower inner quadrant that presents a marked enhancement with an additional enhancing foci, both ultrasound biopsied. Histopathology reported an invasive ductal carcinoma of non-special type, hormone receptor positive, and HER2 negative positive as well. There was also biopsy proving axillary node affection. In the left breast, there is, in the first glance, nothing to highlight, but with the CSM, you can see that there's an additional finding, a 6 millimeters enhancing mass at 12 o'clock position, round-shaped, with another millimetric focus just in front of it. We performed a ultrasound biopsy in what it seemed to be the ultrasound correlation of this lesion, but as you can see, the marker is not even close to the supposed place of the enhancement. So we decided to ask for an MRI. The result obviously was negative. And in the MRI, we confirmed the extension of the right side. And on the other hand, we confirm also the suspected lesion in the left side by kinetics and ADC map. So we have to go again for this biopsy because it does not coincide with the marker. And we decide to offer for the patient the possibility to do it using CSM-GUIDED. And actually it was the first patient with CSM guidance in my department. And before explaining the procedure, let's briefly review the current image-guided breast interventions panel. So far, in cases of enhancing lesions with no clear correlation in other morphological techniques, you only have the MRI guidance. But we do know that this is about to change, and from now on, if we talk about the state of the art, we may include the contrast-enhanced mammobiopsy as well. And that's the final picture. We can face a reality where enhancing only lesions can be approached by both techniques, MRI and CSM. The CSM-guided biopsy is a stereotactic procedure designed to access enhancing lesions that cannot be reliably sampled under ultrasound or mammographic guidance. As in a diagnostic CSM, two images are displayed, one using conventional technique factors, plus a recombined image where contrast uptake is visible. The location of the target is determined by placing markers in the two different angled views. I present you here an overview of the contrast-guided biopsy workflow that we apply in our center. After the contrast administration, we wait for 2 minutes until the breast compression while we adjust the patient position and then obtain the first scout. After that, the additional pair of angled images and plus and minus 15 degrees is performed, where we will select the target and send it the coordinates to the biopsy add-on automatically. Then the web needle introduction. I use a fire forward accessory and I image this, the pre-fire, just to confirm that the tip of the needle is correctly facing the enhancing lesions, because if not, I could have the needle crossing the enhancing lesion. So I also minimize the risk of displacement using this. The sampling time is stable and a clip or marker is placed at the end. To check the marker, even without decompressing, we use one of the 3 available techniques, 2D, 3D, or contrast. But taking in consideration that it would be at least 15 minutes, I recommend the Thomas Scout. So talking about the device, the Serena is an upright add-on unit suitable for both sitting and lateral decubitus positioning. For this case, we decided to go sitting with an horizontal needle approach. This is the software interface. You can switch from any of the other mammography biopsy modalities available. It's important to highlight something here, that the initial workflow of the biopsy is the same of the CSM, the routine CSM. So do not compress the breast before the 2 minutes to allow the perfusion of the contrast. It's recommended to review carefully the case, calculate where the lesion should be located in the breast. You can sometimes perform a scout, a 2D or 3D scout, just to check for the usual parenchymal. So here you can see our first scout, and it was just 31 seconds after the compression. 2 minutes and 31 seconds after the contrast administration. This is a pretty good deal. So we need a stereo pair, like in CSM. Each excision is composed of a low and a high energy exposure, and the radiologist can toggle with both to reliably target the lesion. It's now a matter of choosing the target and any of the preset needles available here, and then send the coordinates to the gantry. The procedure itself, it's like a standard stereo, as I said. This is the pre-fire image. We do not use to acquire post-fire. So after this, I just start with the vacuum, and the sampling time doesn't change. I do confirm usually with a tomo, because it's the same way that I can confirm the presence of a clip, and I can see that the clip is in the same positioning or depth that I initially did the biopsy. In this post-procedure mammo, you can see that the clip is correctly positioned. The final histopathology report was of grade 2 invasive lobular carcinoma of pleomorphic type. Remember that the contralateral was a HER2 positive ductal carcinoma. The second case is a 60-year-old woman with a history of right breast cancer in 2007 and invasive lobular carcinoma. At recent follow-up, we saw this developing asymmetry around the scar. So we recall for CSM, and we can confirm an enhancement that was associated with the surgical scar. But we also saw an enhancement on the left side, more or less speculated. It's the same positioning. You also can see this round ovoid lesion that was a benign fibroadenoma, known and stable, but this is not normal, so there's no ultrasound correlation. We decide to go to the CSM biopsy, and this is the clip. This is the plus and minus 15, and as you can see, the first diagnosis was of atypical ductal hyperplasia, but the final lumpectomy was of high-grade CIS. So it was a good finding, because there's nothing here on the initial mammo. The next case is a 45 years old patient that was on routine follow-up due to moderate familial risk with unknown genetic mutations. We saw on MRI two suspected enhancements, one on the left breast that we biopsied on ultrasound, and this other one on the right that's that you can see on the ultrafast MIP at 60 seconds. Initially, we thought that could be an intramammary lymph node, but not clear. So we decided to biopsy it using CSM guidance and look at this vertical approach. And final histopathology was of an invasive ductal carcinoma plus DCIS. And the patient decided for bilateral lumpectomy. So I would like to review some points that speak in favor of the CSM technique. It's an easy implementation technique, quick to perform, around 7 minutes, and to report. The qualitative analysis is that we've done so far. 30 minutes is scheduled in my department, so it doesn't affect significantly the workflow. And all this altogether favors the rapid diagnosis and the one-stop clinics. During the pandemic, there's something that favors a single appointment, as I told you, the rapid diagnosis, shorter visits, lower recall rates comparing to MRI. Is it possible to avoid ultrasound in some cases and settings, as I told you before? And there's the possibility to avoid unnecessary biopsies. CSM provides clinical useful and readily available information in the symptomatic patients with suspicious abnormalities, increases the detection rate in the initial approach. It's possible to obviate further MRI, and radiology sensitivity, specificity, and size accuracy for breast cancer detection and staging are all improved using CSM as the primary mammographic investigation in some cases, which means that we are optimizing the diagnostic timing and intervals between imaging and final treatment, which means there is an added value. Take-home message, keep in mind that increasing use, CSM is a technique of increasing use. It improves the accuracy compared to normal mammo and mammo plus ultrasound, increases the radiologist's confidence for the first imaging assessment. And the CSM biopsy allows us the identification of enhancing lesions not easily depicted in 2D, 3D. It's fast, accessible, and easy, and allows an easy targeting. Definitely is a potential game changer. Thank you very much for your attention. We can now go to see some questions on Slido. Well, so I have a question here for asking me that how long did I take to the team to be comfortable with the technique? I think that you mean with the CSM technique. It's a very simple technique for the radiographer point of view. I think that the only thing that you have to keep in mind is that you need someone to make the venom punction. So in Spain and in our hospital, the breast radiographers, they are responsible. They had experience of accessing a venopunction. So it was not something that demands a minor training. And for the image acquisition, it's a matter of the standard CC and MLO view. So it's not complicated to implement. Definitely, it's a very easy to implement technique. Someone asking me that I talk about doing recalls when screening with contrast. Yes, we do. what happened is that now we implemented in my department two different kind of recall from the screening. We have a code that's called priority. That is not a lexicon, of course. So it's just a code that we use a P in our report software when we see a lesion that's BIRDS 4CO5, which means that's a lesion that a finding that has a very high possibility of malignancy. So we schedule this patient after this finding directly to a CSM ultrasound, and we also do an appointment for the breast care. So it's a fast diagnosis. So we just pick the patient that has very high possibility of malignancy and included them in the fast diagnosis in order to offer the faster treatment as possible. So it's very simple like that. And sometimes when if the patient is not included in the priority code, it's the standard one, and you think that there's some finding that could benefit you, we have time during the day to offer for this patient a CSM. And it's more important that you can avoid performing biopsies that in the past you had no choice, because the only choice was scheduling this patient to an MRI. So you rather do the biopsy than scheduling an MRI. So right now you just do the CSM at the same moment, and you can decline performing the biopsy if it's negative. Someone asking me about the performance of CSM compared to MRI. Well, this is something very tricky because we cannot forget that the CSM is a standard mammo with a recombined image that has this contrast information. So you always have a standard mammo. So if you go to if you compare, you cannot compare the performance of the subtracted image, that's the one that offers the enhancement, with the MRI. In my opinion, you have to compare the mammo and the enhancing compared to the MRI. If you're talking like this, you always can use the morphological features of the microclassifications in order to decide if it's something that you should biopsy or not. But in my observations, in our experience, the lesions that do not enhance, they used to be low-grade DCIS if they are small, but extensive cluster of classifications, they almost always enhance. And what else? So we are over time now. Thank you very much for your attention.